Hello, my name is Andrew Burkhart, and I'd like to welcome you to the channel, Kentucky Community Care, if you're a first-time viewer, and if not, I'd like to welcome you back. I believe this is the first part of a long series where we will be presenting a bunch of medical education, just some good refreshers for already experienced providers. This one I have here is the Pediatric Emergency Medicine refresher. So you note down in the corner there, it has me as the author. I did author this material. A lot of this material is cited from other resources. I kindly just put this neatly into a slideshow. So at the end, I'll go over citations. It's very important that we give credit to the people who took the time to do this research that I'll be presenting to you today. So I also want to get out a disclaimer that this is by no means medical advice. This is not clinical advice. This is simply a refresher of already pretty well established information that most providers should know. Just a good refresher. Whenever I wrote this slideshow, I did write it geared toward an emergency department setting for already experienced emergency department staff. So this also kind of applies to field providers, but if you're neither of those and you still want to watch, I'm happy to have you. So without further ado, we're going to go ahead and break in to our first section here. So just introduction to this slideshow. Caring for pediatric patients in the emergency department or in any setting is very challenging. The most common reason that I find is challenging in the emergency department is lack of knowledge. That goes for emergency department, it goes for EMS, that goes for people in settings who don't deal with peds all day, every day. It's lack of knowledge. So the way that we combat lack of knowledge and provide better care for these children is continuing education. So we have to continue our education, and I think it's really important we do. I wrote here, even continuing education is an important tool to improve patient experience and most importantly, patient outcome. So we want the best outcomes for the littlest of kids. We want the best outcomes for everybody. So we're going to need to learn and continue our education and grow, and I thank you for choosing this lecture to be a part of that. Pediatric emergency medicine is unique, exciting, interesting, and definitely challenging all in its own regard. So it's important that we have knowledge about the specific pediatric anatomy, their disease presentations, their treatments for their diseases, and any unique challenges. So these kids, and we'll talk about it later, they differ a lot from adults. So in order to understand a lot of this material, it's important we just review the age classification for pediatrics. So newborns. It's pretty commonly regarded now that a newborn is only a newborn for the first few hours of life. And different material shows anywhere from after 6 hours are no longer a newborn. Some material I'm reading goes up to 24 hours, but within that first day, first few hours, you're a newborn. After that, we're going to consider you a neonate. So a neonate is the first 28 days of life. So there's a common misconception that neonates are only premature babies that are born preterm, and that is not true. Those are preterm babies. So neonate, first 28 days of life. Some material showing 30, 31. I think generally the assumption is it's a month. So 28 days, we're going to give that for a neonate. Now an infant is up to 1 year of age, so after you're no longer a neonate and you're up to 1 year. Toddler is 1 to 3. Preschooler, 3 to 5. School-age children, this is the last one that I think has a little bit of leeway in it. So we have it as 6 to 12 here. It's important to note that adolescence begins with puberty. So puberty can start for children young. I mean, we see it as early as 9 pretty commonly. So we're going to say that they're school age until they hit puberty. So 6 to 12 or puberty. So adolescence, and I have it written here as the period between the end of childhood, which is the beginning of puberty, and adulthood. So once they're an adult, they're 18 years of age. That's why we consider an adult clinically. Now legally in different jurisdictions, adulthood, age of consent, stuff like that, all varies. I'm not doing a lecture on that right now. Specifically, clinically, an adult is 18 years of age. Prior to that, they're an adolescent. Now you may say, well, we treat 16, 17-year-olds, maybe even younger than that, as adults pretty commonly with medicine. Maybe so, but for the general population, general regarded, we're going to consider them adult after 18. moving on, um, I have a picture here of a badge backer. So this is a little card that can go on the back of your badge that has all sorts of very important information. So this is vital signs. Because pediatrics, they come with their own vital signs based on how old they are. So it's really hard to remember these normal ranges for kids, even if you see kids every single day. So I carry one of these personally in my clinical practice. I encourage everybody around me to carry one. I'm not sure where I got mine. It's nothing fancy. It's just a laminated piece of paper that I stuck on the back of my badge. But I may be able to find one I can link in the description below for any of you who are looking for one. They're very simple, great tool. So for healthcare providers, like I said, that typically see an adult patient population, these signs are pretty frequently forgotten. I recommend providers carry these badge cards. Often they will. Just a quick reference for normal and abnormal ranges of vital signs. On this card here, you can see we have age groups. We have the standard or normal heart rate, the respiratory rate, blood pressure, both on the systolic and diastolic side, and their mean arterial pressure. We also have at the bottom here what a normal temperature is. That kind of goes for all of them, and it says the oral, the axilla, the rectal, and temporal means of obtaining temperature. So, quick in-lecture citation. You can see here this card has the Child Health and Save on Foods logo on it. I'm sure they produced this material. I did not produce this card, but I am using it, and I think it's a great tool. So, it's important to remember, as you can see by these vital signs if you're taking a look at them here, pediatric patients are not small adults. They're just not. The patients can vary greatly and so vastly from adult patient populations, These patients have unique disease presentations, unique treatments of those presentations, and they have varying common mechanisms of injury compared to adults. And the way we treat the same injuries are different. So you can have an adult with XYZ disease and a child with XYZ disease. Clinically, we're going to treat them maybe completely differently. And that's scary for a lot of providers that want to get into pediatrics. So it's important that we apply evidence-based guidelines that are appropriate for the specific age of the patient you are treating. It's important to remember that the common thing you do for the adults you see in the ER, on the ambulance every single day, even in the clinic every day, may not apply to children and likely doesn't. So I'm going to move on here to pediatric head trauma. Pediatric head trauma, a big thing we see in the ER. And I want to give a little spiel here. We want to be on the prevention side of head trauma. We don't want to be dealing with the aftermath of what happens. So we want to do as many prevention efforts as we can as providers in our daily lives with our own children, with children that we're around. We want to make sure we are doing what we can to take steps to prevent traumatic head injury in these children. So what is head injury in children? A head injury is any kind of damage to the scalp, skull, brain, or other tissue and blood vessels in the head. We often call these head injuries a traumatic brain injury depending on how severe they are. But it's important to remember that just because there's no brain injury does not say it's not a head injury. Those are different things. So a head injury, I have it written here, head injury can be as mild as a bump, bruise, cut on the head. But those are pretty mild things. You think a child with a little bruise on their head, that's not a head injury. That is a head injury by definition. It may not be a brain injury. It definitely isn't a traumatic brain injury if that's all it is. However, it is a head injury. And they can be as severe or worse than a concussion, a deep cut, open wound, broken skull, internal bleeding, damage to the brain. So these are pretty severe. Head injuries are one of the most common causes of disability and death in children. So when we look at head injury and we talk about disability and death, that's why it's so important that we get on the prevention side of things, because we want to reduce childhood fatality. In all regards, we do want to reduce childhood fatality, but we also want to reduce lifelong disability. We do not want these children to have to suffer through a long life of invasive medical care, continuous medical care, and lose their ability to properly do their activities of daily living. So we want to be on the prevention side of this, not the treatment. But when we are on the treatment, it's important we get it right. So what are some causes of head injury in children? There's a bunch. I mean, generally speaking, we talk about children's anatomy. Their heads are huge compared to the rest of their body. They weigh way more compared to the rest of their body, and that's from birth onward for the most part. So we look at sports injuries, falling down, motor vehicle accidents are pretty common. Unfortunately, and I hope you listen to this and you are a little bit more careful when you drive, being struck by a vehicle while walking, pedestrian versus vehicle accidents, are a super common head injury or cause of head injury rather in children. Unfortunately, child abuse and abusive head trauma, we kind of link those together, but those are really common causes of injury too. So we need to be watching out for risk factors for child abuse and stuff like that. When we see patients in clinic, outpatient, when we see them in the emergency department, in the field, we need to really watch for risk factors and be monitoring that. So let's talk about some key points about head injury in children. Like I said earlier, a head injury is any kind of damage to the scalp, skull, or brain or other tissue or blood vessels in the head. And if it affects the brain, we often call it a TBI. So the risk of head injury is very high in teenagers. So you think of children, you think of little toddlers and stuff, but we still need to be watching out for our teenagers here. These injuries are most common in the spring and summer months because children are so active outdoors. And these are important that they have these outdoor activities to develop them and to help them grow and help them be happy. But children that do play sports, they ride bikes, they roller skate, football, soccer, hockey, basketball, all these sports, they are at a higher risk of concussion, a higher risk of head trauma, traumatic brain injury. And unfortunately, that's just the nature of the beast. These children need to be doing their exercise. They need to be outside and playing, and they need to do so safely. Unfortunately, even with all the prevention efforts we can do, we cannot prevent 100% of these head injuries. So, and I guess I should reframe, we cannot reasonably prevent 100% of head injuries. So don't beat yourself up if you lecture this child on proper helmet use, proper personal protection use when they're riding a bike, and they use it all properly, but then something happens to them. We cannot prevent all natures of accidents, but we can try, and we certainly should try. So some symptoms of head injuries after they've had their injury, it includes swelling to the area, headache, sensitivity to noise or light, confusion, nausea, vomiting. Pretty common symptoms we see there with head injury. Treatments for these, they might include rest, even extended periods of rest at times. I mean, sometimes we're not talking a few hours or a few days, but months with traumatic injuries. Rest, ice, stitches. In some cases, depending on the extent of the injury, especially for the more traumatic injuries and the ones that we need to be more cautious of, these children need to stay in the hospital. And after hospital discharge, even for the ones that we're discharging out of the emergency department or we're seeing in the field or the clinic and we're saying, yes, you're good to stay here or you're good to go home, we need to make sure they have the proper resources and the proper environment to be taken care of at home in their environment. We need to be making sure that they have the proper instructions for discharge instructions, for taking care of themselves, what signs and symptoms to look out for, when do they need to come back or call us back. We need to make sure they have proper follow-up care, that they're resting properly, and they're in an environment that they can heal. It's not going to be too stressful, not going to push them to their limits. They need to be able to heal. So some more treatments include ice, stitches. We talked about the child might stay in the hospital, watch more closely. So they also may need to be watched closely, and I say may, they do need to be watched closely for increased intracranial pressure. These are big deal, big risk items here. If we're talking about an increased intracranial pressure in a child who's just had a traumatic head injury event, we have to watch that. So we need to watch out for all the risk factors of that. And I have a last piece here to kind of reiterate the importance of this. Children who suffer a severe brain injury may lose some function in their muscle, their speech, vision, hearing, taste. And they may, and often do, if it's severe enough, they may and often do need lifelong medical and rehabilitation treatment. And this is a sad reality that we subject these children to. So we need to make sure that we are on the prevention side of this. And when we're not on the prevention side, when we're dealing with the aftermath, we need to give them the most quality, exceptional care that we can provide. Now that I've given you that big lecture and scared everyone about their kids' head trauma, let me say that not all pediatric patients who experience head trauma require imaging. And this is a scary point, and it's a point of deliberation amongst practitioners, with parents, with a lot of people. We don't have to scan every kid who gets hit in the head. And there's a tool, a reliable tool at that we can use to evaluate should we scan, should we not. So we're going to get into it. We're going to talk about the PCARN scale. So the California ACEP, American College of Emergency Physicians, they created this infographic. I believe the American College of Emergency Physicians itself is the one that's claiming the PCARN scale. They made it, I believe, and if I'm wrong on that, please correct me in the comments below. So we're looking here at the Pediatric Head Trauma CT or CAT scan decision guide. So this is for under 2 years of age. There is one for above 2 years of age. We'll look at it in just a second. So it's a very easy flow chart. We start at the beginning where the yellow arrow is, and that's on the left, I believe, if you're looking at it. It says GCS under 15. You should look at these as questions, yes or no questions. GCS under 15, a palpable skull fracture, or altered mental status. If there's yes to any of those, we have a high risk, a 4.4% risk of a clinically important traumatic brain injury or a traumatic brain injury that needs acute intervention. So they need a CAT scan. Now, I'm going to reframe and talk about for a second altered mental status in children under 2. What does that look like? We have to ask their caregivers. Obviously, sometimes you can see a very obvious altered mental status of they should be in pain and they're not crying, or they're very slow, but these children often don't talk, and if they do talk, they don't talk well. And unless we see this patient regularly in clinic or something, we don't have a baseline of how this patient is at baseline, at normal. So we need to converse with the parents. We need to take their word for, is this child altered? Have they had a change in mentation? Are they more agitated? Are they crying less? We have to look at everything here about, is this child at their baseline or not? And we have to take the parents' word for it, more or less. So, say they have none of these, none of the first 3 things. Whew, we're in the clear, right? No, we're not. But moving on. Scalp hematoma. That's not frontal. You think kids fall down, hit their face, their forehead, they're going to get a bruise. We don't include that in this. A scalp hematoma, a loss of consciousness over 5 seconds. They're not acting normally per parent. Once again, have to take the parent's word for it. We're not here to argue with the parent of, well, maybe they should do this, maybe they shouldn't. If the parent is telling you or the caregiver is telling you this is not normal for them, we need to listen. A severe mechanism of injury, a fall greater than 3 feet, a motor vehicle accident with ejection, rollover, fatality, bike or pedestrian versus vehicle. This says without helmet. I would say, depending on the speed, even with a helmet. Struck by high impact object. If the answer is no, then we can just observe these patients. They're at a low risk. It says under 0.02%. But if the answer is yes to any of these, they're at an intermediate risk. We call it a 0.9%. It's almost 1% risk. That's too many. If they're yes to any of these, we either need to observe them inpatient or for longer than normal, or we need to look at a CAT scan. Maybe we need to do both of those, but the way we need to do this is we need to use, and we should always use, but we need to use shared decision making with the parent. With your colleagues even on your care team. If you're in an emergency department, you're an emergency physician, and you have the nurses who are saying this kid needs a scan, and you're kind of hesitant. You don't really think they do. And the parents are saying nothing, or they do want to scan, or they don't want to scan. Either way, um, maybe you should reevaluate. If you have other clinical team members, you should definitely reevaluate. This kid may need a scan. And if I did say if the parents don't want it, obviously you have to have consent to do these procedures. But you can give informed consent. You can inform the parents of, hey, at first I didn't think your child met the criteria to need a CAT scan. Some nursing team members they're very adamant that maybe he does, and I'm starting to think that I agree with them, or I'm curious to see what I might find. Is it okay if we scan their kid? Is it okay if we scan him to make sure he has no brain injury? You have to have these conversations. They're often tough, they're frustrating, they're aggravating, and we have to have these conversations. There is a risk that poses radiation for any age group, and especially children, but there's also a risk of an awful fatality or a lifelong disability due to head injury. So we have to weigh the risks and benefits of any of this. Now, I have here clinical factors used to guide decision making. So, has there been multiple of these incidents? Did this kid maybe get on the, well, it's under 2, we're not looking at on the football field, but for older kids, because this is the same wording on the older kids one, were they on the football field and they got hit over and over and over and over again, and finally the last one really did it to them? Now we're concerned? Or was this a one-time thing? Have they had concussions in the past, or is this the first one? Are we finding worsening findings during our observation period? So we say, I think I just want to watch them for 4 or 5 hours. Can we just do that? And parents say, yeah, sure. And they stay in the ER 4 or 5 hours, but the kid is getting more altered. They're complaining of a more severe headache. They're vomiting. Well, we need to really consider maybe we should scan them. This also goes on your experience as a physician or a provider, and it definitely goes on the parental preference. And if they're less than 3 months old, we have a really high rate for head injury, and a high rate and poor prognosis, I guess I should say, for head injury of children less than 3 months old. And we need to make sure that we are taking this seriously. So, moving on to the 2 years and older guide, you can pause and glance over it if you'd like. I'm going to spend a very short amount of time here. Most of the information is the same. The decision guide works the exact same way, except for I see a couple differences. The risk factors are different, so the percentages you can see are different. Severe mechanism of injury in older children is considered different. You can see here we have a fall over 5 feet compared to the last slides that fall over 3 feet. So we need to just kind of consider, if they're 3, maybe a fall over 3 feet is great. But if they're 15, maybe it's not. So, moving on, like I said, I don't want to move on too quickly. Like I said, this guide is very similar to the last one. It works in the exact same flowchart method, and just some of the information is a little bit different. So if you want to pause and look over, you can. I believe lastly here, I want to talk about apparent life-threatening events. So an apparent life-threatening event, and I have the definition, this is a really important topic. An apparent life-threatening event refers to an acute event involving changes in an infant's breathing pattern, appearance, and or behavior. So the National Institute of Health and Consensus Development, they had a conference on infantile apnea and home monitoring. They defined an ALTE, or apparent life-threatening event, as an episode that is frightening to the observer, that is characterized by some combination of apnea, color change, marked change in muscle tone, choking, or gagging. In some cases, the observer fears that the infant has died. That's a pretty big definition there, and it's a lot to take in. So I want to refrain. It does say that this is an episode that is frightening to the observer. When we look at these clinically and we see these patients, they come into our ER, they call us 911 for an ambulance, they come into the clinic. We need to take the caregiver, the parent's word for this. Was it frightening to them? Did it have these characteristics we talked about just now? The apnea, the color change, any of that stuff? Because we weren't there. And it's not talking about this is frightening to the parent that's also a physician, that's been a physician for 20 years in the emergency department. He's not really that scared. It's talking about the lay person who has no medical training. It's frightening to them. So the estimated incidence of ALTEs ranges from 0.58 to 2.46 per 1,000 live births. And it says, and I would think, and I would say from my clinical practice, I can say that this does underestimate the actual incidence of these events. In children under 1 year of age, ALTEs account for less than 1% of emergency department visits. And the majority of these cases occur in children less than 2 months of age. Less than 1%. We are saying that we are seeing less than 1% of these patients in the emergency department. And this is twofold. Number one, we are underreporting these events. We are brushing them off. We are brushing the parents off. We are saying this did not happen, or it didn't happen the way you think it did, or, well, I know you were scared, and I know that he may have got choked, but he's fine now. This isn't a life-threatening event. It was never one. And it absolutely was. We are underestimating these events. We're underreporting these events. Secondly, these are still a small amount of events, and if we stick with the less than 1% number, we're not as prepared for these events as we should be because of how infrequent they may be. So, it's important to note that an ALTE, an apparent life-threatening event, this is a clinical diagnosis that is made with a broad array of symptoms. I have the word in here, constellation of symptoms. I believe that's the exact quote from the article I pulled this information from. It's based on a lot of symptoms put together. And it's based on your clinical knowledge as a provider. And this may not be the only diagnosis you give the child. A lot of places have different diagnosing systems, different ways that we say, you test positive for flu A, we're diagnosing with flu A. But you see also with like stuff like that, you diagnose the flu A, but you also diagnose with shortness of breath. We could diagnose a child, say, that came in for choking with color change, and that it was alleviated by the parent. Parent brought the child in to be checked out. A couple hours later, everything turned out fine. We're discharging them from the ER. We can diagnose them with occurrence of choking and apparent life-threatening event. That's okay. We need to have these recorded and documented properly so we can have more education on them, more research, more data. So, there are a broad array of underlying etiologies. The most commonly associated with these are GERD, seizures, and lower respiratory infections. All of these things in children under 1, especially less than 2, can cause some events that are scary. They're frightening. So this is a very packed slide here, and I won't read over all of it, but I want to talk a little bit about initial actions and primary survey. So what are initial actions that should occur in an emergency department or in the ambulance, in the clinic if you have the right, if you're seeing a same-day patient in the clinic for this, you have the right equipment and clinical staff, what should occur? Well, first and foremost, with all patients, we should rapidly assess them for cardiovascular and respiratory stability. With these patients, when the parent comes in and says, well, he was choking earlier and now he's fine, we need to look at the respiratory status quickly. We need to feel a pulse. That looks at cardiovascular respiratory. We need to look at airway patency. We need to ensure that all these things are grade A, 100%, we're good. Now, how do we do this? How do we do it for every patient? This is no different. They're accomplished by forming an initial impression and performing a primary assessment. Your initial impression is your first look at this child. Some textbooks, when you're taught this stuff, they say, well, your primary assessment is always first, and then you have your initial impression. I don't know where they get that from. When you look at somebody, you have an initial impression of them immediately. When you look at a patient, you have an initial impression of them immediately before you even can think about the primary assessment. You may have been doing this a very long time and already have primary assessed them in 30, 60 seconds, but your initial impressions within that first couple, 1-2 seconds of looking at them. Do they look sick? Sick or not sick? This is the differentiation we're making in the initial impression. We talk about the pediatric assessment triangle when we look at that. So 3 big things to look at for initial impression. That is a little bit different with these. And I mean, we should look at this with every patient. But work of breathing is a big one. Circulation to skin. What color are they? And once again, their general appearance. You can pause and read the note there I have. It's just pretty much that's what I just said. It's got a little bit more information into it. Primary assessment, you know your ABCDEs as a clinical provider. I do not have to tell you what the ABCDEs are. These are no different. If you want to pause and look at them, you're more than welcome to. We also have on this slide the differential diagnoses for an ALTE. There's a bunch, a whole bunch, and I'm not going to go through all of them in this lecture, but they are listed here. This is from the data. I'm going to cite the article at the end of this. You're more than welcome to pause and look at this. I want you to pause and look at this, and I want you to see for the differential diagnosis for an ALTE if they have a category. They have. I'm just going to pick one out here. Let's see. They have a respiratory episode. Something happens in their respiratory area, the respiratory system. That's what you're thinking immediately with this child. You can go down the 4th box down on this flowchart here is respiratory. Over to the etiologies. One of the bottom ones is pneumonia. You can diagnose this child clinically with pneumonia and an ALTE. They're not one or the other. An ALTE isn't a single event. It is not this lifelong thing. It may very well have lifelong effects, but it's not a lifelong diagnosis. It's not a 2-week diagnosis. It's I believe this child, I believe you. When the parent comes to you and tells you, the caregiver comes to you and says this, that, or the other happened, it's saying, I believe you. I believe that this happened. This is why we think it happened. We think it happened because of the child's pneumonia. But I believe you. And it's just documenting that they had this type of event. You believe them. Because you have to think later on, something else could happen to this child, and it could have nothing to do with pneumonia. Medicine is the best guessing game of all time. A very clinically informed, well-played guessing game. High-stakes guessing game, but it is. This event that looked like the child was dying, this was frightening to the observer. It could have been because they had an exasperation of shortness of breath because of their pneumonia. But it could have been something entirely different. And whenever we do chart review in the future, because this child presented with the same thing again, we need to know that they had this before. Diagnosis as an ALTE. Moving on from that, I have a lot of information on the slide. I am not going to read it word for word. I want you to know I have highlighted in red here. Often, the majority of the time, the infant will be asymptomatic on arrival to the emergency department. Or when you get there in the field as an EMS provider, on arrival to the clinic as the same day outpatient appointment, they're going to look fine. That's how it looks most of the time. So if they look fine, we need to get a very detailed history to identify all of the aspects of this episode. All of them. We need to look at all of the patient's history. And I'll get into that in just a second. I want to have highlighted in yellow here, infant apnea is defined as an unexplained episode of cessation of breathing for 20 seconds or longer, or a shorter respiratory pause associated with bradycardia, cyanosis, pallor, or marked hypotonia. It's important you know this definition, as apnea is generally a central component of defining characteristics in an ALTE. So if the patient says they quit breathing, how long did they quit breathing for? Or did they quit breathing and change color? So, back to the questions, the history, the assessment. What are some questions we need to ask? Well, we need to ask a lot of questions, and not to insult anybody's intelligence as a provider, but what questions would you normally ask? Ask them. Ask every question you can think of. Family history, prenatal care, their birth, were they a full-term birth or not? Their medical history from birth to now. The caregiver may not know all of this. You may not have all this in their medical record in your system, but you need to get as much as they know. Their social history, who have they been around, what have they been around today, the last week, the last month even. Their family history. We need to know these things. And we should be knowing these. We should always ask these things, but it's especially important here. So some pertinent questions. When did the episode occur? Who witnessed the episode? What happened right before? What happened right after? When were they last fed? Did they have any symptoms before or after? Were they at their baseline state of health prior? Had they been sick? Maybe they had pneumonia before. Back to the pneumonia scenario. Maybe they had pneumonia. Maybe they had a clinical diagnosis of pneumonia. They're on antibiotics. Now this happens. What are we looking at? There's a broad differential diagnosis for that. It could be an exacerbation of the pneumonia. It could be something entirely different. It could be a reaction to the antibiotics. You don't know. There's a lot of things. The one thing that still stands is that this child had an apparent life-threatening event and they called you. What did this episode look like? Describe it. The color change. How long was it? What interventions were performed by the observer, the lay people? Even if you're a ER doctor receiving this patient from an ambulance, what did they do? What happened? I mean, these are questions that are repetitive, but as I'm sure a lot of you know, after interviewing numerous patients for patient histories, the answers change and each one reveals something new and something different. Which is more information for us to work with, and that's good. So, lastly here, and I mean this is kind of wrapping up this lecture, you can take a look at the pediatric assessment triangle. It's very simple. It's a simple thing to have in your mind. Appearance, work of breathing, circulation. Underneath those are some subcategories of what we're looking for that's abnormal. So, and once again, back to it, we have to take the caregiver or parent's word for this stuff, especially with lessened interactiveness. They're not as interactive. You don't see this child every day. You have no clue if they're as interactive as they usually are or not. Have to take the parent's word for it. So, we need to understand that the patient may be completely asymptomatic, will likely be asymptomatic when they come to our care, but this does not mean that a significant event did not occur, and we should absolutely take the caregiver's word for it, take them seriously. I'm going to leave some citations on the screen here. I'm not sure 100% if these links are still valid or not. These are the links that I pulled a lot of information from whenever I started this. So please just look at these. Give due credit to the people that truly worked hard on this this information, these studies. So I want to thank you once again for choosing Kentucky Community Care for your continuing education. This lecture at this time is not accredited for any continuing education hours, CMEs, CNEs, CEs, none of that. But your dedication to serving your patients does not go unnoticed, and I thank you greatly for that. My name is Andrew Burkhart, and I look forward to lecturing again soon. If you have any questions, please leave in the comments below, or email me, andrew.burkhart, Burkhart, that is, andrew.burkhart at kentuckycc.org. I'll leave my email in the description below. Thank you very much.